Good morning, PTA students. Hope you guys are well. We're going to get started on our shoulder lecture about the shoulder complex. So our shoulder anatomy, we have some superficial muscles that we will go over feeling in class. The trapezius, of course, has the 3 parts. Our deltoid has several parts. Teres minor and major, serratus anterior, somewhat below, but you can feel it even from a superficial level. And then our deep muscles, our levator scapulae, our rhomboids, are underneath those layers of tissue. So in lab, we will work on finding those as well as the rotator cuff muscles and palpating where each one of those are. So here are some of the landmarks, some big muscles that are typically easy to find, so you know kind of where you're at, and the inferior angle of the scapula as well, so that you know exactly when you're on the scapula and when you're not. We will also palpate those in class. Rotator cuff palpation, so your supraspinatus is right there below your clavicle and above the spine of the scapula, so it's kind of under the upper trap. We'll palpate that. And the infraspinatus is right below the spine of the scapula on the back portion. Subscapularis, of course, is on the front portion of the scapula, so it's deep. It's basically underneath your pec muscle. Well, it's even behind that, but it runs along there that you can kind of feel underneath your armpit is where you can enter and feel the subscapularis. So we can do a subscap mode by entering in through the armpit. And then teres major and minor. So remember, it sits, S-I-T-S, so it is supraspinatus, infraspinatus, teres major, and then subscapularis sits, S-I-T-S, supraspinatus, infraspinatus, teres minor, and subscapularis. Okay. There are several areas that can refer pain. Of course, across the body, we've talked about this last lecture with our low back pain, but I just wanted you to be kind of more aware of what refers pain where, and we'll go over those in lab as well. With the heart, it can refer pain to the shoulder, typically the left shoulder, more likely in men than women, that pattern. The right shoulder actually doesn't show it on this because it's a man, but in females, pain in the gallbladder, like a gallstone or just gallbladder issues, can cause referred pain to the right shoulder. So one of the things that we learned in school was fat females over 40. So if they're overweight, it's more common in females and more common with age, over 40 pounds, that have right shoulder pain. Always rule out that they have any gallbladder issues before you just assume that it's musculoskeletal. So take a look at this pain diagram so that you're aware, especially with your neck patients or shoulder patients, that some of the pain in those areas could be coming from an organ. Okay, so first we're going to go over somewhat basics as far as what is typical. It doesn't, we'll go through several of the problems that can cause shoulder pain, but the truth of the matter is most of the problems have similarities in treatment. So regardless of what's causing the pain in the shoulder, most of the time we're going to do passive range of motion on whichever areas are limited. Make sure we're restoring the mobility. We're going to do some maintain the joint integrity, whether that's through joint mobilizations, proper positioning and alignment while they're doing exercises, kinematics, just making sure that the good nutrients are able to reach the joint and the toxins are able to be pushed out, so movements of that joint. We're always going to stretch what's tight. Typically the upper traps and the pecs are the most tight, but you may find some other similarities. Remember, whatever joint you're working on, you also want to look at the joint above and below. So with the shoulder joint, we also want to look at the neck and the elbow. Now, typically, we have more involvement of the neck than we do at the elbow, but we want to look at both and see what areas are tight, what areas are weak. Is there, muscle imbalances or restrictions coming from these areas that are also adding to the shoulder problem. So most of the time I give some neck stretches for most of my shoulder patients, because almost always they have some tightness in either their SCM or upper trap or different areas that they have in common. So we also always want to stabilize. I'll say this several times throughout the lecture, but proximal stability before distal mobility. So at the shoulder, it's a proximal joint. The main focus is getting it stable before we do a lot of strengthening to the mobilizers. So we do want to get the movement back before we do a lot of strengthening anyways, but we want to focus on our shoulder stabilizers, our rotator cuff, our scapular stabilizers, things like that, and make sure that the stability is there before we go doing a whole lot of mobilization. And then strengthening other involved muscles. Typically the rhomboids are a little bit weak, those that pull you back into retraction. Serratus anterior sometimes is weak. That can cause winging of the shoulder blade. That's one sign that the serratus anterior is weak, and so that punching forward motion can help target that. And then we always want to target inflammation, because in any joint, inflammation causes pain, restricts your motion, and can just limit your progress. So we also want to do whatever modalities or exercises we need to target the inflammation. Okay, so our movements for passive range of motion. We will practice those again in lab, but they are internal rotation, that's going down. You can also do it behind the back and go up the back. Flexion, going up. Abduction to the side. Adduction is toward the midline, but it can also be horizontal adduction, which would be across the body. Extension, going backwards, and then external rotation, the moving outward of the shoulder. You all know those, but okay, so our joint integrity, what that requires. So remember, joint perfusion, we're talking about getting proper blood flow to the joint to push toxins out and allow nutrients to come in. And that's really the main reason why we want to maintain, while we do some of these movements, some of the passive range of motion, some of that is to maintain the joint integrity, or the joint perfusion is part of that. So the cartilage integrity is also part of that, making sure that the cartilage stays intact and gets the blood supply it needs. Proper joint mechanics, if part of the capsule is tight and part of it's loose, or whatever, stretching that tight part of the capsule through joint mobilizations in order to maintain good mechanics. And then proper alignment, so that they're able to do what movements they need to do without substitutions or without excessive other movement. So just a quick reminder of all the different joints that are really involved at the shoulder joint. So we have the sternoclavicular joint, the joint where the sternum meets the clavicle. Then at the other side of the clavicle, the acromioclavicular joint, where the clavicle meets the acromion process. Now, if that joint becomes dislocated, really either of those, but that's the main joint that's holding the shoulder onto the body. As you see, the rest is all muscular. We have joints there, but it's really muscles that are holding at the glenohumeral joint and at the scapulothoracic joint. Those are all held on by muscles. So if you dislocate the clavicle either at the sternum or at the acromion process, it's a big deal, because the shoulder will likely sublux and droop, because now the only thing holding it onto the body is muscles. All right, so in any patient, we stretch the muscles that are tight. And typically with a shoulder patient, the muscles that are tight are your pecs. So you could do this corner stretch or the doorway stretch to make sure you're opening up and stretching the pecs. The internal rotators are often tight. So he's stretching the internal rotators there. No, he's stretching into internal rotation so he's really stretching the external rotators. He's increasing his internal rotation. But internal rotators are also tight, so you could go the opposite way. You can do the opening stretch. You can do that in a doorway as well, kind of stretching into external rotation. And then your shoulder elevators, primarily the upper trap. So she is doing the upper trap stretch to loosen that up. Stabilization. So one of the key components of any treatment to the shoulder is going to be focusing on stabilization. The main areas we want to strengthen are the rotator cuff muscles and then the scapular retractors and depressors. So pulling the scapula down and back is the most key, down and back. So with the rotator cuff muscles, we can do internal and external rotation, whether that's with a TheraBand or with a pulley system or isometric. However, we need to start strengthening that. We need to make sure we are strengthening internal and external rotators. They hold the shoulder joint in place as you're doing movements so that there's not impingement, the bones hitting each other. Here she's doing some scap retraction, and here's some shoulder stabilization I've shown you before in class where you start out basically in a push-up position and then you relax one arm and make sure you maintain that flat back. If you start to kind of curve in or cave into that arm, then you're no longer stabilizing. So you need to really hold everything still in that position. Next, we'll go to scapular mobility. Now, one thing, again, we need to remember throughout is proximal stability before distal mobility. So typically when we're talking about distal mobility, we're talking about big movements, your big shoulder movements versus just small like the scapular movements and things. But still, just like the hip, if the shoulder is not stable, then it's not going to allow you to do very good movements distally because you have to be able to hold that position in order to bring the cup to your mouth. If you can't hold that position, then your hand's going to shake all over the place because there's not the stability at the shoulder to maintain that position. That's why it's so key to have stability proximal. Okay, with your scapular mobility, as you see in the picture, as you begin to move your humerus with shoulder movements, the scapula moves with it. So this would be that upward rotation we talk about. And then as it comes back down, you'll see downward rotation of the scapula. But it needs to be able to do these movements in order for your shoulder to have full movement. So if your scapula is kind of stuck or fixed in a place, then your shoulder movements are going to be limited as well. So we'll practice these again, your scapular mobility, but as you'll remember, we did elevation, depression, upward rotation, which is that outward movement of the scapula like we see here as the inferior angle of the scapula becomes more and more lateral with that abduction movement of the shoulder. And then downward rotation would be the exact opposite as it's coming back towards midline. Protraction, the entire scapula, the shoulder blades pull away from midline. They pull more laterally. And then retraction, they're pulling back towards each other. Strengthening. So again, we want to always strengthen the stabilizers before we strengthen mobilizers. The rotator cuff and the scapula need to really be the focus of treatment. Oftentimes people, one reason I put this guy up here, oftentimes people with mobilizers, their deltoid, their traps, their biceps, triceps, all of that is oftentimes already very strong, but typically the rotator cuff cannot lift more than about 5 pounds, and in a very strong individual it may be up to like 10, but it's not supposed to take the brunt of the force, but it needs to be able to stabilize, to hold everything in place while you're moving. So our focus in a therapeutic setting is not typically to strengthen the mobilizers, but the stabilizers. And eventually, when you get to the return to function stage, you may have to do some strengthening of the mobilizers. But again, most of the time, they're strong enough. And what he's doing here, we call the push-up plus. So, of course, you would do your normal push-up down. And then once you come back to the kind of tabletop position, rather than just a flat back, you'll push up against that and round your back out, and that really works the serratus anterior in that punching motion. And so that's always good to do, to add to a push-up, or to even just do just the push-up plus portion in a therapeutic setting in order to strengthen that serratus anterior and keep the scapula from winging. Our modalities, the main focus of our modalities is to target inflammation. So, of course, ice. This is an ice pack that he can wear around and add ice to it. Of course, this is an ultrasound. If there is inflammation, then you would do the non-thermal ultrasound, or pulsed. And then if there is not inflammation, if you're worried more about tightness and restrictions, you could do a continuous ultrasound that has the thermal effect. But all of the modalities we want to use on the shoulder are primarily to target the tightness or the inflammation. Those are the two main areas. Okay, so now we're going to get into more pathologies and specific treatment for these pathologies. We went through kind of some of the things we do for each type of treatment, and we will go over those again in class, but now we want to look at what's causing each pathology and what treatments are or are not appropriate. So with a rotator cuff tear, it could be a partial tear. Here's essentially a full tear of the supraspinatus and a partial tear of the subscapularis. It could be a full tear when it's completely ruptured. That's the supraspinatus that is fully ruptured there and down here. Why is it so common? You hear about people tearing the rotator cuff all the time. Well, the main reasons are because there's a small space there between the bones where these rotator cuff muscles attach. And as you do movements, if you have any impingement, that's the bones coming close together, kind of squeezing, then they squeeze and pinch this area, the rotator cuff. So if they're weak, which typically they are in a lot of people, and you're doing overhead movements repetitively, then over time that impingement is going to wear down the tissues and eventually cause a tear. So it's typically overuse, impingement, and then poor mechanics. So if there's one area that's tight and one area that's weak, then it's pulling it into an imbalance and causing poor joint mechanics, which is allowing for that pinching to take place and the wearing down of the tissues. Ways we could prevent that: if we strengthened the rotator cuff, that would help. It would hold everything in place and avoid the impingement. If we improved our lifting mechanics and, when possible, avoided overhead lifting, that would be good as well, because impingement really doesn't occur until you're above 90 degrees of the flexion. And so even if it's a little bit weak, if you could avoid overhead lifting, then that will avoid a lot of the wear and tear on that area. And then how do we differentiate between a partial or a full thickness tear? Just like with the ACL or others that we've learned about, the partial is going to be more painful, not during the initial injury, but afterwards. So if they come to your clinic, it's been a couple days, and you're assessing, with the partial, there's still fibers that are pulling on each other that aren't torn, and they are irritated. And so as you pull that pressure against the few fibers that are still connected, it's very painful. Versus typically when you're pulling on an area that's fully torn, it's just unstable. There's no tension pulling against you because there's nothing there that's connected. It's unstable, and maybe not even causing as much pain. It may not cause a lot of pain because there's nothing to be pulled, but there is significant weakness. For example, one of the tests that we do, and we'll learn this special test in kinesiology too, but is a lift-off test. So you internally rotate and put your hand kind of where your wallet would be and try and lift it off your back. And if they're not able to lift off at all, that could be a sign that that muscle is torn because there's nothing there to perform the movement to allow you to lift it off. So there would be significant weakness. It may not move at all in that direction. Now, a lot of times the deltoid will take over in certain movements, and so you may see some movement, but there will be significant weakness with a full thickness tear, a full tear of the rotator cuff. Okay, so right after it is repaired, after they've done a surgery and repaired the rotator cuff, you enter maximum protection phase, with the main goal being avoid re-injuring. I have a friend that's been coming, doing a Bible study with me that tore her rotator cuff maybe a year ago or something. Anyway, she's already had 2 surgeries. I don't know what happened the first time, but the second time, within the first 2 weeks of the surgery, she fell and re-tore it even worse than before the surgery. So now she's awaiting her 3rd surgery because she keeps re-injuring it during this maximum protection phase. I mean, you can't help if you fall, but that's very unfortunate because that's a lot of pain to go through. So the main focus is avoiding re-injury. Typically, they are required to wear a brace. Their surgeon will determine. Most of the time, they start out wearing it all the time, and then eventually they can taper it off, maybe only take it off if they're sitting still at home, and then eventually when they're doing some light activities at home. The last thing to go is taking the brace off in public. Because if nothing else, it's good to wear the brace around other people so that they're aware. When people see a brace on, they realize there's something done, and they are a lot more careful, so they're not as apt to come up and give you a big bear hug or hit you on the shoulder as they would if they had no clue or couldn't remember that you had a surgery on that shoulder. So typically, even once you're allowed to take it off for some time at home, you will still be required to wear it in the community, and a part of that is just to kind of cue others and being careful around you. Some of the appropriate treatments, again, the things we have already went over and we'll go over again in the lab, but passive range of motion to maintain or to get more range of motion without them using their own muscles. Modalities, mainly to target inflammation, could target some tightness in the muscles or tissues. Isometrics, now once they are allowed, sometimes it's a few days before they're allowed, sometimes it might be a week or so, just depends on how viable their tissue was when the surgeon went in and performed the surgery. So you're holding it in one position and you're just pushing in against your hand, pushing out against your hand. That would be your internal and external rotation. You could also go down, that's kind of shoulder extension, and up, shoulder flexion. So that's kind of your shoulder four-way. Isometrics, you just move your hand based on which portion you're pushing into. Stretching or movement of adjacent joints and muscles. So you still want to make sure that your neck and your elbow and your wrist and all that don't get tight while they're in the brace as well. So one thing they do is send that ball to squeeze. That's more for maintaining blood flow, maintaining your circulation as you're squeezing the ball, trying to pump the blood through the area so that it doesn't just gather in the dependent position. Doing some neck stretching so that you can keep that nice and loose even though there's a little extra strain on the neck with the shoulder brace. And then your pendulums. Remember, the pendulum, your arm is just hanging and your body is doing the movement. The arm should not be doing any movement other than what gravity makes it do as your body moves. And it's really for that joint effusion to help push out some of the inflammation and allow room for new good blood with nutrients to come in and feed the joint what it needs. It's also helpful in pain gating, kind of allowing the relaxation of the shoulder and decreasing the tightness and helping with some pain. It does not strengthen. It is not a mobilization. It's not for increasing movement. It is to target, to help with joint perfusion and to target the pain. So they should not be doing any active movement of that shoulder during that, which is really hard to get a patient to follow through with. It's hard to teach them the right mechanics for that. And then educating them on what to avoid and what to do, and maybe even how to do new things with their precautions. So now at the moderate protection phase, we slowly begin to progress into our active movement. So again, from passive range of motion, we then go to active assistive range of motion and then to active range of motion. The active assistive, we're showing right here, abduction of that left shoulder, active assistive range of motion, because he has that one he's pointing out with. Here she is doing right arm internal rotation, active assistive range of motion. So the right arm's just hanging out, the left arm is pulling it up. And then here he is teaching her active assistive range of motion for external rotation. Typically we have them glue the arm to the side, not really glue, but figuratively imaginary glue, and push the arm into external rotation. And then as they progress, you could have them abduct about 90 degrees and do it that way as well. And then from the active assistive range of motion, and as their movement comes back to more full range of motion movements, you can start going through the active range of motion as you're allowed based on the surgical protocol as well. You need to always be aware of it and don't start any active movement before it's allowed. We can begin scar massage. Remember, it's necessary to loosen it up and get it to feel and move like the tissues around it while it's still nice and immature, because once it's a mature scar, it's rigid and doesn't move much, doesn't change much. So during this phase, we want to start doing some light scar mobilization. Proximal stability before distal mobility. Again, I'm going to repeat that often because we want to focus on proximal stability, so that rotator cuff strengthening, internal and external rotation, that shoulder scapular stabilization against the wall or serratus anterior as well. All of those things go into stabilizing the shoulder so that you are able to do your distal movements with good mobility, good stabilization of the shoulder, holding everything in place. And then eventually you will start to go through more functional ranges, a little more towards diagonal patterns, coupled movements. And of course, throughout this phase, you'll be addressing muscle imbalances. Stretch what's tight, strengthen what's weak, try and get the best movement without compensation, without compensatory muscles activating and causing other movements. With the minimum protection phase, the focus is to restore function. So at this point, they're basically cleared from the surgeon to go through more and more movement patterns and to do more active and resistance training. And now you're starting to go through strengthening throughout various ranges like diagonal patterns. This is the body blade that can help with some strengthening as well. And a lot of times we'll do diagonal patterns with it. Making sure they have good alignment, taking them through some of their sport-specific movements that they'll need to do to return to their sport, but in a controlled environment. Doing more, body weight training, full body movements, static holds, things like that. And then a lot of times we'll do these weighted ball toss and catch as a resistance exercise, but also a functional exercise to go through those functional movement patterns. So make sure that you are aware of what they are doing when they leave therapy as far as sports and hobbies and all that, so you know exactly what to focus on and what their limitations still are. It might be somebody, they have full movement, but they still aren't able to lift up a plate from the dishwasher and put it in an overhead cabinet. They're still that weak. So then the focus needs to be in strengthening and get them to a point where they can do that. So asking the patient kind of what their issues are and focusing on their particular issues. And that would be the rotator cuff strengthening through the different phases after a surgery. So now we will move on to frozen shoulder. Frozen shoulder is really called adhesive capsulitis. That's really the medical term. However, a lot of people do refer to it as frozen shoulder, and even on the medical script, sometimes it will say that. But a portion of the capsule has adhered to itself. So with chronic inflammation, over time, those cells really are sticky, and they're staying in the area, and they get more and more sticky, less and less mobile, and they basically cause the capsule to just get stuck to itself. It limits shoulder movement. Primarily, it limits flexion and abduction. It's typically the inferior capsule that becomes adhered, and so the main time that you need that movement is during flexion and abduction. It has a usual pathology, so there's 3 stages. Typically, each stage lasts a few months. However, with therapy, they will progress typically more quickly through each stage. So there's the freezing stage where they start to notice that their motion is becoming limited. And that stage, even with therapy, you'll notice it's still getting a little bit worse because it's going through the 3 phases. Even with therapy, you can shorten how long the freezing stage lasts, but it still will get frozen at some point where it has the most limitations. So it's either stuck, kind of fixed in position, or at least the most limited that it's going to get. So don't be surprised when they first come in if it still continues to get worse before it gets better, because maybe you're helping them progress through the freezing stage faster, which means it's getting to the frozen stage where they're most limited, and then becomes the thawing where motion begins to return. Typically, if they don't have therapy at all, this will at least last 6 months, maybe up to 2 years, the whole, all the stages of frozen shoulder. But with therapy, then they could improve within that 6-month time frame, maybe even a little bit faster. But even without therapy, eventually, typically, they get better. But it's just a long process to have painful, limited movements. So here are the exercises for frozen shoulder. Some of the common ones, we'll go over these in class. But again, the pendulum to help still maintain that joint perfusion. We have arm circles, just trying to get some mobility back. Shoulder flexion. We can also, I usually like to do it in the scaption plane. Those are pulleys. That's a pulley exercise she's doing. Can do the tau stretch to stretch the internal rotators. Cross body stretch to stretch the posterior portions of the shoulder and the area. And then the armpit stretch is a really good one to actually try and stretch that inferior capsule, the portion that's the tightest. And so putting your arm on something and then kind of doing, ducking yourself down. So see how our knees are bent? So you would have your arm on something and then pull down to try and stretch that capsule. It could be the table and you're pulling back that way. It could be a ball on the table and you're rolling the ball forward. You can show it several different ways, but it's all stretching the inferior capsule. With shoulder impingement, we mentioned that it is pinching of the capsule as well as the tendons during shoulder movements. Typically, it's in movements above 90 degrees because that is where those bones become most close together and where the rotator cuff really needs to be active in order to hold the humerus in place and down away from the upper portion. So right here you can see this would be kind of your normal shoulder, and here was with impingement syndrome. It has gotten pinched over and over, and so it's inflamed, which then really makes it even more likely to get pinched because it's bigger. So it's really not helping the process. It's just the effects of the process. Often there's muscle imbalances if one area is tight and pulling up hard on that area and the other is weak. So typically it's the rotator cuff that's weak and the deltoid and the upper trap that are tight, that are kind of pulling against it. So also the pecs can be tight and pull you kind of into an internally rotated position. So stretching the tight muscles, strengthening the weak muscles, targeting that inflammation. You may be able to do some ultrasound in the area. Ice is always recommended. Avoiding anything that's causing that. So if they are somebody who works hammering overhead or something often, or painting overhead or something, if they're able to take a week or two off work as you're getting the inflammation under control before maybe they gradually go back. Ideally, they would take even longer off, but most people can't take more than that off. Alter joint mechanics, so make sure that you are feeling for tight areas of the capsule. Typically, it's the posterior capsule that is tight, and so doing that posterior joint mobilization to stretch that portion. Even the inferior capsule, if you need to do an inferior glide to stretch the bottom of the capsule and restore those joint movements. For your reference, I would look at page 555 in your mobility book so that you can be aware of the self-mobilizations and stretches that you can do. We can go over some of those in lab as well. And one thing that I definitely do not recommend in this stage or in shoulder impingement is pulleys. So I know pulleys is an exercise that's used a lot for shoulder patients, and for some, we just saw with somebody with adhesive capsulitis, it would be appropriate to do pulleys to try and increase that range of motion. But for someone with impingement, if they're doing pulleys and already every time they lift their arm overhead, they're banging the head of the humerus up into that acromion process, then all you're doing is causing that over and over again. You're just causing it to bang over and over, and really you're going to make the impingement worse and possibly set them up for some type of tear if it's getting to that point. So I would absolutely recommend no pulleys for shoulder impingement. I really don't recommend them for rotator cuff ailments either, because that basically is related to impingement. I would only recommend them personally for something like adhesive capsulitis where the rotator cuff's fine, it's just there's limited motion when the main thing is just the motion. But you will see a lot of clinicians using them after a rotator cuff surgery and things like that. So just, decide for yourself what you think is safe for the patient. I don't recommend them. As far as the exercise we have now here, she's doing a posterior glide of the shoulder. Remember, that was one of the ways that we could do a posterior glide, joint mobilization of the shoulder. The taping is very good with impingement. It can really help increase and improve the alignment and help also stabilize and assist with the movement of the joint, take some of that pressure off the area. Here is one of those pec stretches where they are laying on the foam and opening up the area so that they're not stuck in that internally rotated position. And then here, although he's doing a push-up, the main thing I wanted you to focus on was the scapular retraction. Remember, scapular retraction is great in strengthening those shoulder stabilizers. So doing that down and back movement where you're pulling the shoulder blades together and down towards their inferior ankle and strengthening in that position. All right, with shoulder subluxation, so it's typically someone who recurrently dislocates their shoulder, and most of the time it is dislocated anteriorly. Sometimes it will be inferiorly. It's rare for it to dislocate posteriorly. So typically the posterior capsule is tight, and the anterior capsule is weak, or there's laxity, too much movement there, which will allow for the head of the humerus to move too much and get out of the joint. So right here, it's two examples of people who have dislocated their shoulder, and if you can fit 2 fingers between the top of the head of the humerus and the acromion process, that is a shoulder subluxation. That is, they have dislocated it. Right here you can tell as well that you could fit fingers there. So you want, in treatment, you want to target the muscle imbalances. Anything that's tight, that's pulling it out of place, you need to definitely stretch. But more than anything is strengthening those shoulder stabilizers, the scapular stabilizers and the rotator cuff. So this is the punches for the serratus anterior. Here he's just doing a wall push-up just to help strengthen the stabilizers. Here, remember the shoulder stabilization training where you're in a push-up position and then you remove an arm and try and maintain good alignment there to strengthen the stabilizers. Here he's doing some external rotation, strengthening the rotator cuff. That's kind of a progression. Typically we start in neutral and pull out, and eventually once they're strong enough in neutral we can go to a 90-degree angle and work out on it there. And then your I's, Y's, and T's are great for some scapular stabilization and mobility, laying prone and then doing I's, Y's, and T's, all to strengthen those scapular retractors. If this subluxation is bad enough, then they would likely be wearing a brace that kind of blocks that, move the picture instead of, blocks the anterior portion of the shoulder. And that would be given by the physician typically. Now, we could probably recommend a brace if they don't have one, or maybe if they're self-referral, and they might be able to find one online these days. Used to, it was hard to find those in stores, but just one that would have a little extra support in the front of the shoulder to avoid that subluxation. Okay, so someone with arthritis, of course we know arthritis is an inflammation of the joint. With degenerative arthritis or osteoarthritis, the joint has begun to degenerate. The chronic inflammation has caused these crevices and craters to develop. So rather than being a smooth joint like it should be, it's rough, rigid. I can't think of a better word besides cratery. And that's painful because then it's constantly just this jagged bone rubbing on each other. When it's a smooth bone, it's just easily flowing and moving within the joint. But when it's all jagged, every portion of that movement becomes painful. With rheumatoid arthritis, you remember that it is caused by an autoimmune disorder. And so it is more systemic. It's not just localized to one joint. It's more systemic, and especially in your distal joints, your fingers and your toes. But for all types of arthritis, the main things we would do stretching, anything that's tight. We would do some mobility. So this is some scapular mobility where you can get against the wall, and this could be for anybody that you're working on scapular mobility. Put your arms against the wall and do kind of arm circles on the wall to help keep the shoulder blades in a good position while mobilizing them. Here he's actually doing some internal rotation isometric. So that's just another way of doing the isometric. You can push in against your hand, or you can push in against a doorway or something like that. Here is a self-stretch and an inferior glide that could be used for this. It could be used for shoulder adhesive capsulitis, or for impingement, or anything where the inferior angle is, or the inferior capsule is tight. So they're holding on to the table and kind of leaning away. It can stretch somewhat the upper trap, but it's mainly trying to stretch the inferior capsule. And then scaption. The reason I have scaption is most of the strengthening for shoulder patients is going to be done, and even just mobility, active range of motion, things like that, in the scaption plane. So scaption plane is not straight flexion, not straight abduction. It's about halfway in between, about a 45-degree angle, and it's a good position for your scapula. And typically with scaption, he's a little high for me. I don't go past the shoulder, so I don't go any higher. The hands stop when they're in line with the shoulder, so they go down to your side slowly, up to shoulder height, and back down. And I typically start with no weight at all. It's just active range of motion, and eventually progress. I would never progress more than 5 pounds. So he's a little heavy on the weight, but it's hard to find people strengthening in that position. So I would recommend no weight at first, and then upping it to maybe 1 pound, and eventually 2 pounds. I typically don't go more than 3 pounds, but definitely not more than 5 pounds. And that's a great strengthening exercise to kind of keep the joint in good alignment while still strengthening some of the stabilizers. All right, with a shoulder replacement, typically, just like any other joint replacement, it's only performed if function is significantly impacted. If the patient is in severe pain and barely able to function, that is the point where they will come in and do a shoulder replacement or a joint replacement in general. So it may be significant arthritis, it may be some type of deformity, it may be different things. Typically it's severe arthritis that has gotten to the point where it's debilitating. They can do a partial shoulder replacement where they just replace the head of the humerus, or they could maybe replace the glenoid fossa. Typically it's the head of the humerus they'll replace. Then they could do a full where they basically replace both. So here is one that's been hammered into the bone. It looks like that one might be a cap or something that they've like glued onto the bone, but this one is definitely hammered in. And here is a reverse shoulder replacement. So a reverse shoulder replacement replaces the socket with the ball and replaces the ball down here with a socket. So it completely reverses now the angle and the joint mechanics at the shoulder. So rather than the top of the humerus being the ball and the glenoid fossa being the socket, now the fossa becomes the socket and the top of the humerus becomes said it backwards. Top of the humerus becomes the concave surface, and the glenoid fossa becomes the convex surface because they've replaced it with a ball and the other portion with a concave surface. So it completely changes joint mechanics. Now remember that we don't do joint mobilizations with a new joint replacement anyway, because it's a brand new joint. It shouldn't have altered joint mechanics. And just the way that they're made, it really shouldn't have altered joint mechanics anyway, but the muscle imbalances can still be an issue. So you still target the muscle imbalances, you still do the other stability exercises, mobility exercises, functional exercises, but joint mobilizations would not be appropriate for this person with a joint replacement. And if at some point you got to a place where you felt you had to, you would have to be very, very careful with a reverse shoulder replacement, because the joint mechanics are completely reversed in comparison to the normal shoulder joint. And of course, mobility, she's doing the pulleys. If everything is fixed within the shoulder joint and all you're needing is mobility, then pulleys would be accurate. If there's a lot of issues with rotator cuff and stuff, I still wouldn't do the pulleys. But scapular retraction, internal and external rotation, starting out with isometrics and eventually progressing, and of course the pendulums at the beginning just to get the shoulder moving. So the main focus is getting everything moving and full movement, because really with the shoulder replacement it should be pretty stable, but you can still do some rotator cuff and scapular strengthening. All right, with the biceps tendonitis, of course, that's swelling in the biceps tendon. You want to decrease the load on the tendon, so definitely not recommending carrying boxes or working out doing bicep curls or anything like that. But you can also tape the area. You can also perform stretching so the muscle's not so tight, loading the tendon itself, in order to decrease the load. Other areas that are commonly tight, the pecs are typically tight, so stretching them. If there's anything up in upper trap or neck that's tight, you would also stretch that. You may even need some rotator cuff strengthening. A lot of times biceps tendonitis and rotator cuff tendonitis kind of occur simultaneously in people, so checking and seeing which of those muscles are weak and then strengthening those. Of course, you want to address the inflammation, making sure that whatever's causing the inflammation, that you kind of nix that and stop the cause, but also that you use whatever modalities that you need to decrease the inflammation. So ice, possibly pulsed ultrasound. Eventually, if it's in a chronic stage, you could possibly do a continuous ultrasound. Active movements to make sure you're continuing to get proper joint perfusion. You do want to correct the posture. These are reverse shoulder rolls, rolling towards the back. At this last one, it looks like he's rolling towards the front, but we don't. We just go down and back. Typically, that's the way we need to go because typically people are already pulled to the front. And then make sure that they are educated on proper resting, on stretching, and limiting repetitive motion. So if it's somebody who's just doing this by working out too much, then, educating them on limiting the repetitions, decreasing the weight, especially for now while we're focusing on decreasing inflammation, but also long term to keep from continuing this cycle. Now, the last thing we're going to talk about is tendinitis versus tendinopathy. With tendinitis, it's just the inflammation that is in the tendon itself, so it's just irritated and inflamed. But with tendinopathy, it occurs after there's been chronic inflammation, and that chronic inflammation has now caused the tissue to start to break down. It's become weak and compromised. Basically, some of the fibers are disrupted, they're disorganized, and it's easy to tear. That's the issue. With tendinopathy, it's become weak and more likely to tear. So with that, we need to be more aware with our treatment to protect the area, to avoid a tear, to really control the motion. So it goes through phases kind of like with a rotator cuff repair, where you're trying to first protect and strengthen in a very protected manner, and then trying to get the motion back, but targeting the muscle imbalances so that the motion is good and not causing more inflammation. And then eventually, once they're able to do things in a more pain-free and you kind of have targeted the issue, then you can do more of the return to function and start going through functional movements, diagonals, getting them back to where they need to be. Now with that, as far as modalities, I like ultrasound for tendons. I find my patients typically like it, so I could use it for tendinitis or tendinopathy. If it's acute inflammation, I would use pulsed. If it's more chronic inflammation, then I would use continuous. But that is a great way to really help heal a tendon. Ice, of course, is going to be good as well, especially if they are returning to exercise or activity. Use ice in order to really target the inflammation that's causing it in the first place. Okay, so the remaining slides are just case studies, so we will go over those in lab together. If you have any questions, please let me know, and we will do the rest of it in lab. So have a good day.